Hi, everyone. Welcome back to another episode of CHD Unpacked, a podcast about living with congenital heart disease. This podcast is brought to you by the Canadian Congenital Heart Alliance. I'm your host, Amanda, and today we'll be unpacking the topic of clinical exercise testing in congenital heart disease. We're very excited to be joined by today's guest, Dr. Barbara Cifra. Dr. Barbara Cifra graduated from medical school at La Sapienza University in Rome, in Italy, and completed her residency in sports medicine, focusing her training in cardiology and exercise physiology. As a trainee, she worked at the Medical and Surgical Pediatric Cardiology Unit at Bambino Gesù Children's Hospital in Rome, studying how the different types of physical activity impact heart function in children with acquired and congenital heart disease. Dr. Cifra is the director of the exercise medicine program at the Hospital for Sick Children in Toronto. The program provides healthy lifestyle plans and exercise recommendations for children with heart disease. Dr. Cifra is also the director of the lifestyle medicine program at Toronto General Hospital, where with her team, she provides exercise prescription and education to adult patients with CHD. Please join me in welcoming Dr. Barbara Cifra. Hi, Dr. Cifra. Welcome to CHD Unpacked. Thank you so much for joining us today.
Thank you so much for having me. It is a pleasure to be here.
So today we're going to be talking about clinical exercise testing in congenital heart disease. And to start us off, would you be able to tell us a bit about the scope of your practice?
Of course. I work in Toronto at the Hospital for Sick Children, where I direct and run with a group of people a program called Exercise Medicine Program. So my team is composed by a physiotherapist and a registered kinesiologist. The scope of the program is to provide patients who are living with congenital heart disease with personalized exercise plan. We actually do lifestyle personalized plan. So we talk about exercise, sleep, nutrition, sedentary behavior, and then we do a comprehensive clinical assessment. And based on the specific congenital heart disease and the result of the test, then we're able to support our patients with specific plan. And we follow them for several months. And we help them increasing their physical activity level, but also their cardiopulmonary fitness. So this is the main part of my job.
Great. Thank you so much for sharing that with us. Can you explain in a bit of detail your clinical approach to assessing someone's cardiac function and their exercise capacity if they have congenital heart disease?
So when patients are referred to the program, we do a first risk stratification. Is something that I do. There are published articles that suggest how to do that in order to prescribe an exercise plan to a patient who has a heart condition. The first thing is to look at what type of lesion they have. And the second one is to look at what is the cardiac function. So what we do, we have, of course, all this data at the hospital. So we look at an ultrasound of the heart to look at the cardiac function. We look at their ECG. We look at if they have done MRI. We also look at that to kind of complement the information that we can have from an ultrasound. And we put everything together. Probably also, if there is a previous exercise test, we can look at previous exercise test, what information that we can gather, and we can go in detail into that. It can be a 6-minute walk, it can be a regular exercise test, or it can be a cardiopulmonary testing. And then we bring the patients to the hospital. So the main test for an exercise prescription, which is the gold standard in any program that prescribe exercise, even in adult, is a cardiopulmonary testing. The cardiopulmonary testing is a test on a bicycle or on a treadmill. We prefer a bicycle for technical reason. And with that test, we can look at how the heart responds during exercise, how the blood pressure responds during exercise, because we have some stickers on the patient's chest, so we can look at the ECG during exercise. We do multiple measurement of the blood pressure during exercise. And then it depends on different centers have different equipment, but the idea is that patients wear a mask, or so they breathe in a mask connected to a machine, or their nose is clipped and they breathe in a mouthpiece. And so we analyze the gas exchange. That is the part where we collect metabolic data. And with that part, we can detect a patient-specific cardiopulmonary fitness. And this is the information it's really key in order to prescribe exercise for aerobic exercise. And other things we do at SickKids in my program, because we're thinking to activate, to empower patients and, in my case, children to be more active. There is also a component of looking at their muscle and how their muscle performance is, the level of strength, the quality of the movement, their physical literacy. So the physiotherapists and the kinesiologists take over that part. And then we put these two data together. So data about cardiopulmonary fitness and data about musculoskeletal apparatus. And then based on that, and then also based on the counseling session that we have with patients, then we're able to really provide a personalized plan for them. So I would say that the key tests are tests that they look at what is the current cardiac function of the patient. And remember, the ultrasound, MRI, or sometimes you have to look at additional tests. Those are done in resting condition. So they give us some specific information. But then we have to look at how the heart responds to exercise. And an exercise test is the key test for that. And then if we want to go an extra step deeper into the assessment, then we can do a functional assessment of strength or quality of movement or physical literacy. That depends on the age of the patient.
Okay. And for someone that might be living with congenital heart disease and wondering why they need to be having so many different kinds of tests, that kind of explains it. Do you want to see them at a resting state and then how their body will respond to different levels of exercise? So I think that's really important for people to hear that all these different things kind of work together to give you the full picture.
Indeed. Mm-hmm. The majority of the tests that we do in cardiology for patients with congenital heart disease, if you really think about it, are done in resting condition. So in ultrasound, the patient is laid down on a bed. In the MRI, you're laid down in the MRI bed and machine. And an ECG, you're really still in resting condition. But if we want to really understand how the heart function when a child is movement or an adult with congenital heart disease wants to go to the gym or wants to go for a bicycle ride, then we really need to test patients in a dynamic way. And the only way is an exercise test.
For sure. And when you speak to your patients about potentially needing to do tests like this, do they ever ask you how they could best prepare to come for a test like that?
There are some specific rules for cardiopulmonary testing specifically. So we generally say that the patient has to be at rest for 24 hours prior to the test. So if it's a patient that is active, we ask them not to exercise the day before the test, because the cardiopulmonary testing is a maximal test. We want to see the maximal capacity of our patient. So we want to make sure they have the full energy to complete the test. It's quite challenging. And we have to remember that it's a test that is diagnostic, but is also a test that gives us performance information. It's actually a test that we never think about it, but athletes do that test to assess their level of fitness. And based on that test, we provide information also to athletes on how to train at the right intensity. So we're doing the same things with patients. So it's a test that usually patients are used to. Different centers start at different age, but generally speaking, everybody who was born with a heart condition, around the age of 10 or 9, they start doing stress tests, so exercise testing. And that can be a regular one without the metabolic part, but it's still an exercise test. Or if the center has availability, then they do also the cardiopulmonary testing with the metabolic data. Okay. So we just ask them to rest and then obviously not to fast, to have a breakfast in the morning. And those are just the only two things that patients need to worry, if you want to use that word, about.
Okay. And if someone is unfamiliar with the term metabolic data, can you explain what that means and how that helps inform decisions that you make about their care?
Yeah, so while a patient is exercising, either I said on a bike or on the treadmill, then the fact that they're breathing in this closed system, we're able to analyze the gas exchange where they're breathing. And there is a very sophisticated software attached to the machine that analyzes this gas. And then we can look at different parameters. So of course, we look at the heart rate, we look at the blood pressure, but then generally speaking, there is two parameter that I generally talk with my patients. There are many information that come out of this test, and some are very complicated, but the one that are really good to kind of talk and understand why this test provide information that no other test can give me is that we measure something that we call peak oxygen consumption. So it's basically the ability of the body to use oxygen as energy. So we're measuring that, and we're measuring that during a ramp exercise. So the intensity progressively increase.
Okay.
And at one point, we tap into the anaerobic metabolism. So at one point, the type of oxygen that I'm giving to the muscle is not enough anymore for the muscle to produce energy. And so there is this shift in anaerobic metabolism. And we're able to look at how this parameter changes with exercise, with this increase intensity exercise. We're looking at the moment where there is the shift, and then we're looking at the final number where the patient usually says, I cannot sustain in terms of the bike, I cannot pedal anymore at the RPM that we advise, or it can be leg fatigue, it can be fatigue, it can be, I'm exhausted, this is my limit. Yeah. And so then we look at the parameter of peak. So in this test, so I usually look at the peak oxygen consumption, which is the let's say the maximal exercise tolerance that the patients are in that test.
Okay.
And there is a number that we measure, and then we have reference values. So we can see, is that patient's exercise capacity or tolerant what we expect for someone his age? Or if it's below, what is the difference between what we're measuring and where the patient should be? And that can help us determine that there is a margin of optimization. I always like to talk in terms of optimizing health and optimizing exercise capacity. Mm-hmm. And then, of course, the number is influenced by different factors. It's not just influenced by am I active or not active? It's influenced by what type of lesion or condition the patient has. Additional comorbidities. We also look at the pulmonary function before doing the test. So if we have to also take that into account, the age, and then other factor, but definitely if someone is active or not truly affect the number. And so when we do that test, the result of the test is used to guide our patients in terms of what does it mean to exercise at a moderate intensity, at a vigorous intensity, which is the intensity level that usually is needed to improve our exercise capacity. So if we are active, but we are active below a certain intensity, it's still good for us, but is not helping our conditioning, is not helping to increase our exercise capacity. So with that test, we're actually able to give specific target for intensity for our patient.
Okay. So by taking into account all of the information based off of their own personal fitness, their lesion, their pulmonary and their cardiac function, you're able to see what's the maximum amount of exercise that they can do and then kind of tailor what's feasible on a day-to-day basis.
Yeah, in terms of quantity is different because some patients want to exercise. Quantity is done in minutes in an exercise prescription. So in exercise prescription, we use the FIT formula. And FIT formula is just help us prescribing it. FIT is frequency, intensity, time, and type. Okay. So the frequency is how many days per week is the prescription to exercise for that patient. So how many days in the week are this patient's active days. Mm-hmm. The cardiopulmonary testing really helps us with the intensity. So we want to make sure that what we prescribe is appropriate to that patient's level of exercise tolerance. Okay. We don't want to prescribe an activity that is out of their level of exercise where the patient gets overwhelmed and they cannot sustain the activity and maybe it's not safe for them. So with that test, we really can guide the patients to what type of activity is good for them, what level of intensity is good for them. And then in terms of quantity, that is done in minutes and really depends on the work that you do with the patient. We use that formula to prescribe exercise in the same way we prescribe any other medical therapy.
Mm-hmm.
But the difference between prescribing a medication and prescribing exercise is that it's a teamwork. So it's something that I guide my patients to talk about what activities they like, what they have available, and then we put everything together, the result of the test, their preference, what they have available, into this prescription that is personalized for them.
Okay. Great. It sounds like a very comprehensive approach to patient care.
It is. It is something that is really, I'm happy to see that many centers now, both in pediatrics and also in centers that take care of adults who live with a congenital heart disease, and an approach that is really taking over.
For sure. And does this approach also help you predict any long-term complications that someone with congenital heart disease might have?
Yes, generally speaking, patients do a cardiopulmonary testing during their entire life when they're in the pediatric age, but also when they transition to adult care. And what is the reason why beyond the exercise prescription we do this test? Because the value that we measure with that test, and I said it's called peak oxygen consumption, or we want to measure the exercise tolerance, it really tells us the strength of the body of our patients, if you want to put it that way. And then it's not just related to the ability to exercise, it's also related to the ability of sustain daily life activities. And when the number becomes very low, then our patients might start struggling with daily life activities. And we have to keep in mind that physiologically, in any individual, that number tends to decline with age. Mm-hmm. So that is a physiological effect of aging. However, if you have a heart condition, the rate of decline is faster. So it's even more important for our patients to counterbalance this effect of aging with having an active lifestyle. I would say that it's one of the best insurance one can have on their health. Mm-hmm. And I think we should empower and talk about the power that our patients have over their health, because the heart condition is something they were born with. And sometimes some of my patients, they feel defeated because I was born this way and it's not something I can change. But I always say it's not something we can change, but with something we can make better. And you have the power to make it better. And I think having an active lifestyle is one of this way to use this power. So health optimization is all about empowering patients to have and feel control over their health.
For sure. And can you elaborate on some of the social implications of someone having potentially a better understanding of their exercise capacity? Like, how could that benefit them in their life?
So the reason why patients with congenital heart disease are not as active as, let's say, their peers, as multiple factors. It's not just because I have a heart condition, therefore I cannot exercise like my peers, because there is no evidence nowadays showing or saying that our patients cannot exercise and cannot match the national guidelines for physical activity, both in the pediatric age and in the adult age. And I think the problems start in the pediatric age. And the reason is, first of all, is the overprotective approach of parents. And you can imagine, I have a child who went for heart surgery, or even if he didn't have surgery, but has a heart condition. So I might try to ask my child not to exert himself or herself too much. Mm-hmm. And that comes from a lack of counseling from medical provider and taking the fear away from the parent. So I think the first one is the family environment. The second one is, and it's changing, it was also the medical environment. We were not trained as physicians, and we're still trying to embrace more this type of approach in the management of patients with congenital heart disease. We were not trained to prescribe exercise and talk about exercise. Mm-hmm. And so that was a lack from our side. And then the third component is me, my as an individual, what is my confidence in my ability to move and exercise? So that's called self-efficacy. So if children are restricted from parents, and sometimes even that happens at school, parents don't receive specific information from the medical from the doctor. It can be their cardiologist or also other figure that are involved into the care of those young patients. Then the kids doesn't really play with his peers, and that affects his confidence because he's not learning the basic movement they are needed to complete more complex tasks. And so this is a vicious cycle that it starts early on in life, and then the patients themselves don't feel good enough to exercise. They don't know what to do. And so I think the benefit of prescribing exercise and to have this conversation with patients to reverse this negative vicious cycle, especially towards exercise. So I think we should educate, we should teach these patients how to move. We should tell them that it's important to exercise because they can participate in the gym class, and then the social benefit of that when you're a child. Also in the adolescent phase, they might feel more confident to join a recreational program. And again, then there is the peer support and the social aspect. But this is also very important when you're an adult. If you want to join the gym or you want to join a recreational program, you need to feel confident enough that you can do that specific activity. And I think the social benefit comes from empowering these patients, work on their self-efficacy, and that is the first step for them then to explore opportunities in the community.
Mm-hmm. And it sounds like the feeling of safety that kind of comes from counseling from their medical team is really providing a foundation for them to be able to go out and try things themselves and kind of expand what they're confident in doing.
Yeah, I think as physicians, we have a very important role in this because sometimes we're very good in talking about restriction for physical activity. So unfortunately, for some patients, some activities might not be ideal. And we use the term restriction. And as I said, we're very good at that because we have clear guidelines about that. Because for competitive sport, we have evidence and expert consensus. We have guidelines about that. So some patients cannot practice competitive sport. But then the mistake in the past was to just stop at the restriction. And so we never had the time then to talk about promotion of physical activity. If certain activities are not ideal, there are other activities that are ideal for that specific patient. And so I truly believe that restriction and promotion are not mutually exclusive, but there are two sides of the same coin. And I think what makes the difference when we talk with patients is that they need to understand that the intensity and the type of exercise is where the personalization needs to happen. But in terms of can I exercise, is it good for me? That is absolutely no reason to tell a patient not to exercise. Anybody can do something.
Thank you for saying that. I think that's really important for people to hear and to kind of get that confidence and to hear it from maybe they need to hear from multiple medical professionals to kind of feel that confidence and overcome the fear of exercise, depending on previous experiences that they might have had.
Yeah, and I also think that sometimes having a good conversation with your doctor about physical activity can also prevent that maybe as a patient I engage of activities that are not really ideal for me because I don't really know, maybe I don't understand fully my physical ability or my exercise capacity level or why a certain sport might not be ideal for my specific physiology. So I think it's also good that patients can ask specific questions because in my experience they do have very specific question about exercise.
Mm-hmm. If someone's wondering how often they should get exercise testing or have that evaluated by their physician, what would you say to them?
Well, there are no clear guidelines about how often to repeat an exercise test. Generally speaking, in big center is based on availability, but also the individual cardiologist decision. I would say, so some patients do it once a year, some patients do it once every 2 years. I want patients to understand that if the cardiac function is okay, even if their center doesn't provide a cardiopulmonary testing, the doctors still have information to guide them for physical activity. So if we look at the gold standard, ideally, yes, I have a cardiopulmonary testing. But if in some center the cardiopulmonary test is not provided, the physicians still have the ultrasound, the MRI, a regular exercise test, and can still guide patients in terms of an exercise prescription.
Okay. And if someone feels like they might want to adjust the prescription that was given to them, how would they go about doing that? Should they contact their physician, or should they try things themselves?
I think they should contact the physician. Like if I am on a medication, on a medical therapy, and I have question or I feel that the medication doesn't have the same effect anymore, and I have question, I go back to the physician. I don't double the dose without asking. So I think it's the same for an exercise prescription, just to have a follow-up question with the doctor about what the patient wants to talk about. It can be, how do I progress my exercise routine, or can I include this new activity in my exercise routine? Or if I'm having symptoms, are the symptoms normal or are not normal? So there is something also that we can use exercise testing to educate our patients. I think especially the one that they fear exercising. It's very common to have a patient who lives with congenital heart disease reporting shortness of breath or difficulty breathing with exercise. But I think most of the time, especially when we start telling them then they can exercise, there is this misconception that if I increase my breathing with exercise, that I'm out of breath. And for me, it's not good because I have a heart condition. So the tests on the bike can also be used to teach how the body reacts normally to exercise and educate patients how to differentiate between a true shortness of breath that has to be reported to the physician or just the physiological response of the body to exercise, which is an increase in heart rate, an increase in the rate of breathing, and also in the depth. And then I start sweating, and then I feel, so those are normal feelings. But sometimes they are considered symptoms from some patient.
Yeah, I think when someone has a chronic medical condition, it can become very easy to become very in tune with any change that you experience in your body. So I think it's important for people with congenital heart disease to know when it's the time to worry and when it's okay, and certain things are to be expected.
And those are very important questions that I think patients should feel comfortable asking their doctor, because this is part of the education and this is part of the empowerment and getting to know how your body works.
Right. And do you find that there's ever difficulty within your patient population in terms of sticking to the regimen that's outlined for them in their exercise prescription?
The difficulty can come for different factors. First of all, when you do an exercise prescription, you're asking your patient to change in behavior. And compliance is an issue even with any medical therapy. So it's a process. That's why I think one-time conversation with the patients is better than nothing. But I think the patient should be able to have a conversation like on several times, maybe when they see the physician, because changing behavior is not easy. So it can be sometimes a little bit of lack of motivation. Sometimes there can be barriers that are external to the patients. It can be the resources that they have available. Sometimes there are not many resources at home, or there are not many resources in the community. There can be some logistic barrier. There can be some financial barrier. So I think it's important to understand that all these factors, they should be addressed when talking about exercise, and ask the patient what is the level they're willing to start with. That's also the personalization. So we do know that for children, the national guidelines recommend an hour per day of physical activity. For adults, it's 150 minutes per week. But we need to meet the patients where they are at the moment. And also that means not just their exercise capacity, but also where do they feel they can start this to change their behavior towards physical activity, because it's a journey. Are they ready to start the journey into improving their physical activity level? And if so, where do they feel comfortable starting?
And you spoke about kind of expanding the scope of exercise promotion and making that more available within the assessment of those with congenital heart disease. Are there any barriers that you've identified in terms of making that more general scope of practice so that more people are able to receive exercise prescriptions, such as what you do with your program?
I think what is changing is that now exercise prescription and certain principle of exercise science, they're being integrated in the curriculum of medical school, which I think is the right step, it's the right direction. Because I don't think physicians were not counseling patients because they didn't want to. I think the problem is sometimes lack of time and sometimes it's lack of knowledge. And so we're starting to addressing this, the roots of the program, so medical school. And then in terms of, I think another barrier could be the fact of resources. So you can imagine that in a busy clinic, this is not a conversation that it can be done in 2 minutes. It needs a little bit of extra time. So also every physician has to decide in how to manage their clinic and maybe account some extra time for exercise counseling. One way can also be the one of having some resources material that can be given to patient, and it's something that it's like an education pamphlet or link to resources that are online. And so then the conversation can continue at the follow-up clinic. I also think that in order to create programs like the one that I run at SickKids, it's costly, so there is a cost for that, and not every center has the resources to build the program. But I think every physician can, and now they're trying to have this conversation with patients. So it's something that we're going to start to see more often until it becomes standard of care. And I think we're getting there.
Well, that's great to hear that it's expanding, starting from the roots of medical school and further from there. And if some patients are looking for more resources and they want to educate themselves, maybe between appointments with their cardiologist or with their medical team, are there any resources that you can point them towards that could be helpful?
I mean, the AHA website has a lot of resources in terms of physical activity and the benefit of physical activity for someone living with a congenital heart disease. There are several websites that can provide general information about the benefit. I think after a patient is clear from their cardiologist and have a conversation with them, I think they can kind of also, like anybody else who wants to start being active, once they're clear, they can look up at information online. If I want to start a routine of walking, if I want to start a routine of jogging, or if there are no restrictions, then the parents can look at recreational program for their children. There are no specific website. I think the AHA is a comprehensive one.
Great. Thank you so much, Dr. Cifra, for joining us today and for providing your expertise from everyone at CCHA. We're happy to have you.
Thank you for having me.